Good afternoon, Philippines. It's me again, John. Walang magawa. And it's 11:33 po ng gabi dito sa akin. And I believe it's almost 2 in the Philippines, 2 p.m. So, hi there. And hello to all our students watching right now. I know we don't have class today. I mean, I don't have class with you today. But I believe I will meet you on March 1st. That will be tomorrow, right? March 1st, my time zone. Anyway, before I'll start, I want to say hi to Jebony Nunez, Sonia Rojas. Hi there. And hello to Raquel De Castro. He's from Davao City. Hi, sir. Uy, Raquel, I hope na check mo na yung email mo. I sent some, I think one review material for you. Good luck sa examination mo this month ba yun or next month? Okay, so nakita niyo naman siguro sa title, I'll be talking about burn injury. Now, why so sudden talk about burn injury? Well, may nangyari kasi kanina. But anyway, hello to Teresa Medidas. Hi. And we have somebody watching from Saudi Arabia. Hello, Miracle Dagalea. Hi there. I'm just glad, guys, that you're still there. No, kahit na wala akong definite na schedule. Depende lang sa mood ko kung kailan ako mag-live. But you're still there. Thanks a lot. Yeah, hi Teresa. Hi there. So yun nga nangyari is I have a friend who texted me early this morning and then he told me, "Hey John, I need some help." Gusto niya magpatulong with regards sa pagkabit ng battery ng sasakyan. And then he told me, "Pwede ba yung tawag nito? I-jumper na lang natin yung sasakyan ko sa sasakyan mo." And I haven't tried doing that. I know it's risky kasi if you put those wires in the different terminals or wrong terminals, it may cause fire. Right? So instead of helping him, baka masira pa yung sasakyan ko. So we'll talk about burn injury. And one more thing about sasakyan, may isa tayong it's an old news actually. May isang artista dati na yung kapatid niya yata at saka papa niya namatay because of carbon monoxide poisoning. So I think we'll talk about burns. Something to do with carbon monoxide as well. Hello to Epi. Hi there. So we will talk about burn injury today. We'll define what's burns. What do you mean when you say burns? We'll talk about the different classifications of burn injury. Then we'll talk about the TBSA, the rule of nines. And then I'll give you the common complications of major burn. And then I will give you a brief pathophysiology of major burn injury. And how do we usually treat patient with major burns? Diba? Agad lang. Hello to Jerry Echo. He's watching right now. Hi Jerry, kumusta? Si Epi, avid ko to na ano eh. Avid ko na watcher. Watcher! Watcher talaga. Anyway, hello to Monelia Talipaco. Hi there. And hello to Tita Jane Abejo from California. Hi there. Kumusta tita? Dito na ako sa America, hindi pa tayo nag-meet dalawa, no? Anyway, how's Kim? Anyway, guys, so we'll talk about burn injury, and I hope that this will help you if you will take your NCLEX RN or any qualifying examination soon. Okay? Oh, by the way, just a heads up, don't forget the new generation NCLEX will kick in April 1st of this year. Okay, so there will be a new test format for the NCLEX RN. And if you don't have any idea what it's all about, I think I posted a video about the NGN. And if not, you may search and add the website of or the Facebook page of US Review Center. Anyway, hello to Riza Basilat. She's watching direct from UAE, Abu Dhabi. Oh my God. I've never been to UK, to Abu Dhabi, in Dubai as well. I'm planning to go there this coming November. Plano ko talaga doon ako mag-birthday ng sa Dubai. Hopefully. I'll just cross my fingers. Anyway, hello to Bernadette Aguilar. Hi po, kumusta? Okay, I think everybody's ready. Don't worry guys, I won't delete this Facebook live. And for the information, I'm doing this stream as well, simultaneous with my YouTube account and some private Facebook pages as well. Okay. By the way, if you have any questions about the concept or anything you want to ask, please drop a comment there and I will try to answer that. If I don't know the answer, I will let you know. Okay, let's try to silence the background music. There. Oh, hello pa. Hello to Stephen Henry Chin. Hi, Stephen. Kumusta? Stephen was my student before during his college days. Isa sa mga very noble student, very humble. And I'm so proud of you, Chin, of what you're doing right now and what you've achieved. Okay, so let's talk about burn injury. Let me share my screen. Okay, entire screen. Oh, meron parang papabati. Hello to Donna Te Bercades. Thanks for watching. Okay, whiteboard. Wait, what do we have here? Ito yung topic ko last time. So we'll talk about burn injury. Okay. What was that? Here. Okay, burns. Okay, so when you say burns refers to tissue death or cell death due to exposure, okay, in a heat source. So technically, pag sabi mong burn, it refers to cell death, okay, or tissue death or tissue injury, okay, due to exposure. Okay, exposure where? Exposure in a heat source. In a heat source. Due to exposure in a heat source. Don't forget that the longer you expose yourself from the heat source, the more severe will be the injury. Okay? So I just want to make it clear. The longer you expose yourself from the heat source, the more severe, the more serious the injury will be. Okay? And in your examination, don't forget that the burn injury are actually classified or based on the area or the layer of the skin affected. Okay? So we have this, what we call first degree burn, okay? Second degree burn, third degree burn, and fourth degree burn. Please be reminded of the common layer of the skin affected. Okay? First degree burn affects the epidermis. And by the way, we know this in your anatomy that epidermis is the outermost layer of the skin. Okay? Second degree burn, okay, injury affects the epidermis. and the dermis. So basically, the first and second degree burn will not affect the entire skin layer, just part of it. That is why we also call first and second degree burn as your partial thickness. Okay, partial thickness. Okay, but it doesn't end there. Sometimes in your examination, they will use other terminologies. Okay, especially for your first and second degree burn. First degree burn affects the epidermis, which is the superficial layer of the skin. That is why sometimes they will not use the term first degree burn. They will use the term partial thickness superficial. Okay, so you also call this as your partial thickness superficial because it affects the epidermis that happens to be the superficial layer of the skin. The second degree burn affects the epidermis and the dermis, and the dermis is the deep layer, the layer under your epidermis. That is why sometimes in your examination or in your NCLEX, they won't use the term second degree burn. They will use another term for this, and we call that as your partial thickness dip. Okay, so you also call this as your partial thickness dip. So please don't confuse yourself. Okay, now what about third degree burn? Third degree burn affects the entire skin and it affects your subcutaneous tissue. Okay, fourth degree burn is quite serious because of the layer affected. It affects the entire skin of the patient. It affects subcutaneous layer. It affects muscles of the patient and sometimes deep down to your bone. Okay, so the entire skin is affected down to your bone. Okay, but technically, when you say third and fourth degree burn, these are burn injury that affects the entire skin tissue or the skin layers. Okay, that is why third and fourth degree burn is called or referred as your full thickness. Okay, so don't forget that. Now, what I want to emphasize again will be the common presentation of your patient. Okay, common presentation of your patient. Now, look, first degree burn is commonly presented as redness. Okay, and of course, medical term for this is your erythema. Erythema or redness. Second degree burn, okay, common presentation here is blister. You know blister? The thing with the fluid underneath, it's actually contained and there's a fluid underneath. Okay, that's your blister. And guess what? Second degree burn is considered to be the most painful. It is the most painful injury. Okay, I will explain that in a bit. Okay, third degree burn. Okay, third degree burn is actually characterized by a scar. Okay, a scar and edema. That is why there's a scar formation in edema. It increases the risk of compartment syndrome. Okay, compartment syndrome. I just hope that you were around when I talk about when I gave a lecture about fluids and electrolytes, wherein we talk about compartment syndrome. Okay, remember compartment syndrome is a condition wherein there is compression of tissues and circulation underneath because of edema and inflammation. In short, as edema progresses, as inflammation worsens, it adds pressure, okay, on the skin because the skin failed to expand. Okay, so as a result, when edema worsens, okay, when inflammation aggravates, it adds pressure underneath, so circulation is actually affected. You call that your compartment. And don't forget, compartment syndrome is most common to patient with third degree burn. Why on patient with third degree burn? Because it's where a scar and edema are common. Now, what about fourth degree burn? Common presentation here, actually, it's painless. And it is characterized by a charcoal colored skin. Charcoal colored skin. Okay, so please don't forget the presentation. Now, what about the healing process? Healing process. First degree burn usually heals in about 5 to 7 days. If you have other figures, that's fine. If you use other textbook, that's fine. Okay. Second degree burn heals in an average of 21 days. Okay. Third degree burn, since it affects the skin of the patient, in order for healing to kick in, there must be skin grafting. Skin grafting. And for fourth degree burn, skin grafting is essential. Not only that, since it affects the bone of your patient, it is also paired with what we call, what do you call that? Amputation. Okay, so these are the different conditions and the different classifications of burn injury depending on the layer of the skin affected, as well as the common presentations of the patient and of course the healing process. Okay, so lahat naman siguro tayo nakaranas ng burn injury, right? Anyway, here's the situation here. Here is our, anyway, may nagtatanong. Raquel De Castro, sir, meron kayo lecture fluids and electrolytes? Yes. Meron po, Raquel. Can you check na lang sa account ko, sa page ko, or if not, go to YouTube. May na-post ako dun sa YouTube. Okay, so let's go back. So just a reminder, anything that generates heat can cause burn. I said that. And I mentioned that the longer expose yourself, okay, from the heat source, then the more severe will be the injury. So one good example here is your burn injury from sun exposure, from sunlight. That's your sunburn. Okay, that's your sunburn. The longer you expose yourself to sunlight, the more severe will be the injury. Or you can have a burn injury because of chemical injury, chemical burn injury. Pag-genius effect ay nasunog, na short circuit, at pumutok, ayan, burn injury out of chemical. Don't forget this in your NCLEX. If you suspect a chemical burn injury, you flush to the site the burn injury in a running water. Okay, a running water, or if not, okay, you do irrigate. You do irrigate the site with your normal saline solution. Okay, and that's your burn injury out of your chemical source. This is another burn injury because of fire. Nasunugan ng bahay. Ayan, no, nakita ko lang to sa internet. Kinapit ko lang. I don't know who owns this picture, but credits to the owner. And this is the most common type of burn injury out of fire. Okay? And of course, pwede ka rin na magkaroon ng burn injury because of electric burn injury. Now, thing to remember here, if you develop burn injury out of electrocution, don't forget that there's always a risk of your cardiac arrest. Because remember, if you got electrocuted, it may disrupt the normal conduction in the heart. That is why one of the most important nursing responsibility if a patient develop or sustain burn injury out of electrocution is to assess the heart rate of your patient, because again, it may increase the risk of your cardiac arrest. Okay. Okay, so look at the different layers of the skin affected here. So this is your first degree burn. Okay, this is your first, what's that? Thank you, surgeon. Welcome. Okay, this is your first degree burn. Look, it affects the epidermis layer. And I said that the common presentation of a patient with first degree burn is your redness. So this is an example of your redness. Okay, where's that? Okay, this is your redness or your erythema. Okay, redness or erythema. So sunburn is an example of first degree burn. Okay, this is your second, by the way, your first degree burn, I mentioned this, your first degree burn is also called partial thickness superficial injury, right? I said that. This is your second degree burn. It affects your epidermis and dermis. Okay, you also call second degree burn as your partial thickness deep injury. And I said that this is the most painful injury, right? Help, ang sakit. Ayan. So this is your second degree burn. And I guess I mentioned that the common presentation of patient with second degree burn is blister. So this is your blister. Okay? Lahat naman siguro nakakita ng blister. Thing to remember in your examination about blister, do not try to pop the blister. Okay? Do not pop the blister, because the moment you pop the blister, sabi nga ng Pringles, once you pop, you can stop. Hindi po. Once you pop the blister, it increases the risk of infection, because normally, if the blister is intact, okay, if the blister is intact, it serves as a protection from the external environment. But if once you pop the blister, there's already a break in the skin, okay? So that exposes now the burn injury to the external environment, increasing the risk of infection. So do not pop the blister. Okay? And this is your third degree burn. Okay, third degree burn involves the entire layer of the skin and okay, your subcutaneous tissue, that's your fats. And I said that the common presentation of your third degree burn, you have your scar and edema, correct? Scar and edema. And I guess I mentioned that common complication here, concern will be your compartment syndrome. Okay, I already mentioned that. And this is your fourth degree burn. Okay, it involves the entire skin of the patient down to the muscles to your bone. So in order for healing to kick in, okay, to start, there must be skin grafting and amputation. Okay, so these are the different burn injuries. Okay, these are the different burn injuries. Well, let's go back. Where's that? Okay, now you've seen the different burn injuries, so I hope you store all those stuff inside your cerebrum about the different layers of the skin affected, as well as their common terminologies, common presentations, and the healing time. Now, what I want to talk about now will be the evaluation or rapid assessment of the burn injury. So, the most commonly used rapid assessment for burn injury is the rule of nines. Okay, rule of nines. Add stream. Where is that whiteboard? Here. So this is the rule of nines. Rule of nines. Rule of nines. Okay. The head, okay, is 9%. Okay. Just a reminder, the head includes the neck. The entire head that includes the neck is 9%. But if in your NCLEX examination, they specify anterior part of the head. So, na-specify na anterior lang, hindi buong head. So, if it's only anterior, that will be 4.5%. Okay? Pag sinabing posterior head, again, that's 4.5%. So, in your examination, be very cautious with the terms anterior, posterior, upper, lower. Okay? So, anyway, head is 9%. Each arm, okay, each arm is 9%. So each arm is 9%. Anterior of each arm is 4.5. Posterior of each arm is 4.5. Or sometimes they will use the term anterior upper extremity. So if it is anterior upper extremity, only one extremity, and it's the front part and anterior. Okay, anterior front part, so that will be 4.5. So be cautious with anterior, posterior, upper extremity. Extremity, singular, extremities with S, plural. Okay, so please be careful of those terminologies. Okay, what else? You have your anterior thorax. This will be 18%. So when you say anterior thorax, that will include the chest and the abdomen. So if in your examination, they use the term abdomen. So pag abdomen lang, hindi buong anterior thorax. Abdomen lang, that's the half. So pag abdomen lang, it's 9%. Pag chest lang, it's 9%. Pero pag buong anterior thorax, that's 18%. Okay? Don't forget that. Next, posterior thorax. Posterior thorax is another 18%. In short, that's the back part. Next, each leg. Each leg, that's 18%. So this is preferable to your lower extremity. So when you say lower extremity, that's 18%. Pag sinabing anterior, lower extremity, harap, lower extremity, that's 9%. Pero pag sinabing anterior, lower extremities, plural yon. Okay? We have two extremities, lower extremities, the right and the left. Anterior, that's 18%. So tandaan lang, each leg is 18, anterior is 9, posterior 9. Both legs, that would be 36. Okay? And of course, last here is your perineum. Perineum is 1%, a total of 100%. Okay? A total of 100%. Now here is the, hey, where is that? I think I have. Ito pala. Your head is 9%, each arm 9%, each leg 18, anterior trunk 18, posterior trunk 18, perineum 1%, a total of 100%. Diba? Thank you so much, Board of Judges. So this is the illustration. So here, 9% the head, that includes the neck. Anterior thorax, it's 18. Each arm is 9. Each leg is 18. Okay, perineum, 1%. Posterior thorax is 18%. Okay, now, highlight in your examination. Please do not forget that if you will be asked to compute for the TBSA, make it sure that you will get it correctly. Because eventually, if you fail to get the TBSA correctly and you have to compute for the fluid resuscitation of your patient, mali na yung computation mo. Kasi part ng fluid replacement ng pasyente, therapy, is to compute for the TBSA. So pag mali na yung computation sa TBSA, mali na lahat. So be very careful when you compute for the TBSA. Okay? And I will teach you how to compute later on for the fluid replacement. Now, another highlight in your examination, we know what burn is. We know the different classifications of burn injury. We talk about rapid assessment of burn injury using the rule of nines. The question now is, how many percent TBSA is considered to be a major burn? Anybody? How many percent TBSA is considered to be a major burn? Anybody? A major burn, ako na lang. A major burn injury is a burn injury with a TBSA of greater than 25%. Other book, greater than 20%. Usually that's for adult. Okay? But for children and elderly, a TBSA of greater than 10. Other book, a TBSA of greater than 15. Okay? Pakisulat nga, Sir John. Saglit lang. Okay, here. So when can we say that the burn injury is major? Okay? It is a form of a major burn if the TBSA is greater than 20 to 25% for adult, greater than 10 to 15% for children, and elderly. Pero usually ang ginagamit ko yung greater than 25%. Okay, for adult. That is why for those who were with me when I talk about burn injury in the actual review program that we had a few weeks ago, I used 25%. But other book, greater than 20%. Alam mo naman ng iba-ibang author, iba-iba yung ginagamit na numbers. Bakit hindi na lang kayo nag-reunion? Bakit hindi na lang kayo nag-conventional lahat ng mga authors? Tapos, tawag dito, nag-usap sila. Ito, ang gamitin natin na numbers ito para uniform lahat. No? Pinahirapan talaga tayo. But anyway, same with the values. Napansin nyo? Pag itong book ni ganitong gagamitin mo, ito yung normal value para sa kanya. If you use the book authored by this one, that author has a different value as well. You know? But anyway, wala tayong magawa. Okay? So anyway, so what I usually use is a TBSA of greater than 25. Okay? Now, what I want to emphasize now are the different systemic complications of burn injury. Okay? So I'm going to clear them. Okay, clear my whiteboard. So there are several systemic complications. Systemic complications. When you talk about systemic complications, I am referring to major burns. Okay? Major burns. Number one systemic complication of a major burn injury is that there will be hemodynamic instability. Hemodynamic instability. So what do you mean when you say hemodynamic instability? There is problem, there is unstable perfusion, there is problem with circulation. Okay? So when you say hemodynamic instability, this condition, this complication begins immediately. Okay? So this occurs This occurs immediately, okay, upon blood vessel wall injury. Okay, now if you were present when I talk about fluids and electrolytes, hindi kayo mahirapan dito. Okay, remember, this is your blood vessel. Okay, the fluid inside the blood vessel is your plasma. The fluid outside the blood vessel, outside the cell, is your interstitial. Correct? And these are cells outside. Okay, so the fluid inside the cell is your ICF. The fluid outside the cell is your ECF. Your ECF is divided into two compartments, the plasma and the interstitial. Correct? Now, look what happened to burn injury. So there's exposure to heat source. Okay, there's exposure to heat source. If there's exposure to heat source, it injures the blood vessel wall. Correct? Ibig sabihin, when the blood vessel now is injured, it increases its permeability. Correct? Okay, having said that, if the blood vessels now are injured, okay, it will increase its permeability. Once the blood vessel is permeable, it will be easy enough for fluid to get out. You now call that a shear fluid shifting, correct? And sometimes you'll be asked in your NCLEX examination, what is the movement of fluid during this condition? The movement of fluid will be from plasma to interstitial. Other book, we call that your intravascular fluid to extravascular fluid. Okay, so having said that, when the fluid gets out from the vascular compartment, what will happen now to your blood volume? Definitely the blood volume will decrease because the fluid gets out, correct? So when the blood volume decreases, you call that condition as your hypovolemia, correct? There's a decrease in the blood volume. And if not treated, if not corrected, this hypovolemia can progress to shock. And we call that as your hypovolemic shock. And remember, if there is hypovolemic shock, regardless of the type of shock, if the patient is in the state of shock, technically there is altered perfusion. There is impaired perfusion, and that indicates hemodynamic instability. Okay, so this condition happens immediately if there is blood vessel injury because of what we call fluid shifting, secondary to increased vessel permeability, secondary to what we call injury, okay, due to heat exposure. Remember, I just want to say it again. The longer you expose yourself to the heat source, the more severe will be the injury. Okay, so what will happen now if you have hemodynamic instability, if we have poor perfusion, blood flow to the different vital organs, blood flow to the different vital organs are actually affected, resulting to organ failure. And that is the second problem. So you may end up having organ failure. Oh, shout out to Miss Kathy Mas. Hi, Kathy Mas, kumusta? Organ failure. So there is no perfusion, there is no good perfusion to your brain, no blood supply, no enough blood supply, no good perfusion to your kidneys. So eventually we'll end up having renal failure, acute renal failure to be specific. And what type of ARF? We usually call that as your pre-renal failure. Pre-renal failure is a type of acute renal failure related to perfusion problem. Okay, number 3, patient may end up having this what we call respiratory dysfunctions. Okay, now why did the patient develop respiratory dysfunction? Okay, what are causes, what reasons, okay, can you think why patient end up having respiratory dysfunction? Of course, letter A, because of hemodynamic instability. Hemodynamic instability. Okay, letter B. Oh, I miss you to Cathy Mas. Oh, by the way, class, Cathy Mas, kabatch ko yan nung college. My God, he's a good singer, professional singer. My God, I miss your voice, Cathy Mas. Anyway, so another reason why you have respiratory dysfunction is, of course, because of inhalation injury. Inhalation injury. That is why please don't take this for granted in your examination. If you happen to see some, what do you call this, remnants of mga usok sa ilong ng pasyente, okay, most probably nilanghap ng patient yung usok, and it may cause inhalation injury. Okay, and part of your inhalation injury, letter C, is that it may lead to, or it may give you a complication or a problem called carboxyhemoglobin. Carboxyhemoglobin. Sir, what is carboxyhemoglobin? A carboxyhemoglobin is a condition wherein the blood of the patient binds with carbon instead with oxygen. Okay, sir, I don't get it. Normally, sir, normal naman na nagbabind yung blood natin sa carbon. Correct. Okay, it binds with carbon dioxide and it binds with oxygen. Okay, but here in burn injury, it's different. Look, I'll give you the normal physiology first. Now, remember, this is our blood. This is what we call the RBC, red blood cells. You also call this erythrocytes. Inside the RBC, okay, inside, by the way, what is the normal RBC count? What is the normal RBC count? 4.5 to 4.8? I forgot. Millions per cubic millimeter. Okay, anyway, the normal RBC, inside the RBC, there are molecules or pigments. Okay, you call these molecules or pigments inside the RBC as your hemoglobin. Hemoglobin. Your hemoglobin is divided into two. Okay, we have the hem and the globin. Okay, I said, and I think we know this, that the RBC carries gases. Yeah, the hem and the globin will carry those gases. But specifically, what gas binds with hem? Hem binds with oxygen. Globin binds with carbon dioxide. This is the normal thing. This is the normal physiology. Normally, the RBC carries two gases, the carbon dioxide and your oxygen. Ito yung normal. But what happens if you have carbon monoxide poisoning is that pag malanghap mo yung usok, malanghap mo yung carbon monoxide, okay? Carbon monoxide, okay? Pag nakita siya ng blood, nakita siya ng hem, ang gagawin ng hem ay bibitawan niya ang oxygen. Okay? Bibitawan niya yung oxygen. Palitan natin yung kulay. Here. Okay? Bibitawan niya ang oxygen. Didikit siya ngayon sa carbon monoxide. Why? Why is that so? Because ang true love talaga ng hem ay carbon monoxide. Ito yung true love niya. Ibig sabihin, the affinity, just want to make this analogy. Okay, but of course, technically, hindi naman talaga yung nangyayari na in love yung mga hem. Okay, just for the purpose na madali nyo maintindihan. The affinity of carbon monoxide towards your blood is 100 to 200 times greater than oxygen. Ibig sabihin, pag nakita ng blood ang carbon monoxide, mas pipiliin ng blood, ng hem, ang carbon monoxide than oxygen. So it displaces now your oxygen. So what will happen to your hemoglobin? Your hemoglobin now is filled with carbon. Ano yung carbon, sir? Carbon monoxide and carbon dioxide. Can you see that? Instead of bringing oxygen and carbon dioxide, the RBC now carries carbon monoxide and carbon dioxide. We now call that condition as your carboxyhemoglobin. Okay, so carboxyhemoglobin is technically a condition wherein the blood binds with carbon monoxide and carbon dioxide, displacing oxygen. Okay, so having said that, a patient with carboxyhemoglobin, what is the problem now? The problem here is that it decreases oxygen carrying ability. Okay? Why? Because wala na mapagdiktan yung oxygen. Okay? In short, ano na yung oxygen? Rebound. Oh my God, rebound. Okay? Kasi yung totoong mahal niya talaga ay carbon monoxide. Okay? Now, another thing to remember in your NCLEX. Hem binds now with carbon monoxide. Globin binds now with carbon dioxide. That is why if gases, okay, these gases now are present inside your RBC, expect that if you use pulse oximetry, you will have a normal reading in your pulse oximetry. Okay, so tandaan nyo yan ha. Do not use pulse oximeter if you suspect carbon monoxide poisoning because the result in your pulse oximetry will be normal. Magugulat ka, normal naman yung O2 sat, sir, dyan. No? Tingnan mo, 95 to 100% normal. Correct, because hindi tinitingnan ng pulse oximetry machine what type of gas is there. Tinitingnan niya lang kung may gas. May nakita siyang gas. carbon monoxide and carbon dioxide. Hindi niya alam kung anong klaseng gas yun. Oxygen ba yun or carbon monoxide? So take note, we discourage you using pulse oximeter to check O2 saturation if you suspect carbon monoxide poisoning. Okay? Because it will give you a false result, a false reading. Now, you mentioned, Sir John, carboxyhemoglobin. You mentioned, Sir John, carbon monoxide poisoning. Yes. So a little topic ng carbon monoxide poisoning. Carbon monoxide poisoning. What is the normal carbon monoxide level? The normal carbon monoxide level is less than 10%. Okay? And what is the usual hallmark? Okay? What is the usual hallmark of carbon monoxide poisoning? The patient appears intoxicated. Patient appears intoxicated, hallmarks. And patient with carbon monoxide poisoning will also end up having cherry pink, okay? Cherry pink, okay? Face and skin. And take note, this cherry pink colored is actually reversible. Now, if you suspect carbon monoxide poisoning, what do we do? Your nursing action here, okay, your nursing action is to give 100% oxygen via a tight fitting non-rebreather mask. Okay? A tight fitting 100% oxygen via a tight fitting non-rebreather mask. Kung present po kayo sa pag-discuss ko the other day, I talk about oxygenation at present ko doon ang mga different oxygen interfaces. Okay? Check nyo na lang yung ano yung mukha ng non-rebreather. Okay? Na-discuss ko yon. Okay? Na-discuss ko yung nasal cannula, na-discuss ko yung simple face mask, na-discuss ko yung venturi mask, partial rebreather, non-rebreather mask. So you check it out. Okay, so that is your nursing responsibility. That is to give 100% oxygen via tight-fitting non-rebreather mask until such time, okay, until such time that the carbon monoxide is less than 5%. Okay, less than 5. Other book, less than 10. Okay, less than 10. Okay, I hope this is clear. I hope this is clear. Next, number 4. Fourth, systemic complication of a patient with major burn injury. Fourth complication of a patient with major burn injury. Patient will have, what do you call this? Hypermetabolic response. Hypermetabolic response. Why do you have hypermetabolic response? It's because of the massive injury sustained by the patient. Okay, so this is a normal reaction of the body because of the massive injury, massive burn injury. What I want to emphasize here will be the implications. So what are implications? What are implications if you have hypermetabolic response? Letter A, an increase in your metabolic response will result to increase in your hydrochloric acid production, which is a normal physiologic response. Am I right? So as a result, an increase in your hydrochloric acid will lead to development of stress ulcer. Now you call that ulcer as your stress ulcer. Okay. Now what is another name of stress ulcer? Another name of stress ulcer is your Curling's ulcer. Curling's ulcer. Curling's ulcer. Please don't confuse yourself. We have different. If you're familiar with medical surgical nursing, ang dami mong ma-encounter na ang first name niya ay Curling's. We have this Curling's triad. We have Curling's ulcer. Okay? So marami tayong tandaan dyan. Okay? Meron din Cushing's triad. Okay? Anyway, Curling's ulcer. So you also call that a stress ulcer. Meron din Cushing's ulcer. Okay? But anyway, ang Cushing's ulcer is a form of Curling's ulcer specific only to patient with neurologic problem. Wala ka napansin, yung mga pasyente na may stroke, yung may mga pasyente na may neurologic disorder, binibigyan natin ng anti-ulcer agent. Prophylaxis yun sa Cushing's ulcer. So Cushing's ulcer is a form of stress ulcer or Curling's ulcer specific only to patient with neurologic problem. Okay? Letter B. Another implication, if there is hypermetabolic response, definitely tataas po ang calorie demand ng patient. There will be an increase in the patient's calorie demand. Yes. It increases patient's calorie requirement, calorie demand because of the burn injury. Ang tanong, ano ba yung normal calorie requirement? The normal ranges from 1,800 to 2,400 calories per day. 1,800 to 2,400 calories per day. That's the normal. But for patient with major burn, okay, since increase ang calorie requirement, it ranges now from 6,000 to 8,000 calories per day. Dang, that's a lot. Kaya mo bang kainin ng 8,000 calories per day? Ang dami nun na. So that is why doctors will opt now for TPN. What is TPN? Total parenteral nutrition. Okay? So if you will be asked, what do you think is the diet of patient with burn injury? Okay? Diet will be high in calorie, high in protein, high in carb, high in fats, okay? High in vitamins. Why do we have this modification? Because you want to promote healing or repair. Okay, healing or repair. Next, letter C. Letter C. Another implication, letter C. There will be an increase in your metabolic acid production. So it will increase the risk of metabolic acidosis. Okay, next, number 5. Fifth, systemic complication of a major burn. Remember, we're talking about systemic complications. First was hemodynamic instability. Second is organ failure. Third is respiratory dysfunctions. Fourth will be hypermetabolic response. Number 5, you will have sepsis and immune dysfunctions. Now, why do we have sepsis and immune dysfunction? My God, that's self-explanatory. Why? Remember, in burn injury, it injures the skin, and skin is considered to be the first line of defense, right? So if there is a break in the defense, then it will increase the risk of infection. So the problem here is there is high risks of infection. Having said that, what will be your priority for a patient with risk of infection? Don't forget this, it's reverse isolation. Okay, now just a heads up, sometimes in NCLEX, sometimes other qualifying exam, they don't use the term reverse isolation. They use another term, protective isolation. They call this as protective isolation. Protective isolation. So apart from that, doctors will give antibiotics. So what's the common route or route of antibiotics here? Doctors may give a topical antibiotics. Doctor may give IV antibiotics. We discourage giving meds IM or sub-Q. Why? The burn injury will affect absorption of the medicine if you give that sub-Q, if you give that IM. So you better give it topical or intravenously. Okay, for topical, one common medication given here is Silvadene. Okay, now what is the generic name of your Silvadene? The generic name of Silvadene is not silver nitrate, silver sulfadiazine. Silver sulfadiazine. Okay, don't forget that if your patient is receiving silver sulfadiazine or Silvadene, it's normal that they will feel burning, okay, burning sensation when you apply Silvadene. I mentioned silver nitrate. Silver nitrate can cause discoloration of your skin. Okay, next, number 6. Another complication of a patient with burn injury would be pain. Siyempre, sino ba naman dito ang nasunog or napaso na tuwang-tuwa? Okay, so there is pain. So we give here analgesic. Okay, usually we give morphine sulfate. Okay, how often we give morphine? Tandaan lang that the safest morphine is that we give 1 to 2 milligrams of morphine every hour. 1 to 2 milligrams of morphine every hour. 1 to 2 milligrams every hour. Okay, until the pain goes away. Just a heads up: if your patient takes morphine, watch out for addiction. You watch out for what do you call this? Depression. You watch out for hypotension. That's part of your depression. And if you have morphine overdosage, don't forget that the antidote is your Narcan or naloxone. Okay, Narcan or naloxone is also given not only to morphine but to patient with heroin toxicity and codeine toxicity. You have the Heromoco, heroin, morphine, codeine. So Heromoco, heroin, morphine, codeine, they have the same antidote, and that is your Narcan or naloxone. Okay. Next, number 7. Of course, another systemic complication here, patient will have emotional trauma. Emotional trauma. Okay, I cannot discuss emotional trauma, mga therapeutic communication, because I am not expert about therapeutic communication. You wait for your psychiatric coach. Baka mali-mali yung sasabihin ko dyan. Okay. Anyway, let me check if you have any questions. Anyway, shout out muna kay, who do we have here? Pamela, yep, hi there. Map Bebe. Hello to Chris Sabordo Montaire. Hello to Rafea Mia Miraato and Kathy Openia, Amy Niere, and Hartenia Ahmad. Okay. Anyway, if you have any questions, let me know. And here, who do you have here? Thank you, Sir John. I know 5.1 to 6M. What is that? What is that 5.1 to 6M? Carbon Lodi. What's carbon Lodi? Hi, sir. I miss you. Haha. From says Rochelle Garcia. Hi there. Says Rochelle answered non-rebreather. That's good. 6 to 8 calorie intake. What do you mean 6 to 8? That's 6,000 to 8,000 calories. Okay. And now let's continue. So these are the different and common complications, systemic complications of a patient with major burn injury. And hello to Jean, Diana. Hi there. So let's try to check. So this is just a very brief, pathophysia of your burn injury. Okay. So I said that a burn injury, major burn injury, is a burn injury with a TBSA of greater than 25%. Okay. We're talking about adults. Okay. So technically, a major burn injury will give you 4 issues. What are these 4 issues? Number 1, okay, it can cause cell lysis. Okay. Then you may have here a possible, no, you have here inhalation injury. Ito natin ilalagay. Inhalation injury. Here, lagay natin break in the physical barrier. Here, lagay natin, syempre na injured, exposed ka sa extreme heat, will be injury in the blood vessel. So, lagay natin dito, blood vessel wall injury. O, diba, taray? Let's begin with your cell lysis. Okay. By the way, shout out to my friend, Ian John. You're at work. Why are you watching my live? Okay. And Bal, hello. So anyway, this is your, ano ba yan? Dito natin ilagay. Dapat konti lang para madali siyang i-erase. This is your blood vessel. Okay. And these are your cells here, the RBC, WBC platelet. If you can still remember the PISO, this is the technique, the mnemonic for your electrolyte placement, particularly for your cations. When you cations, these are positively charged electrolytes. So, sorry. PISO. PISO is the technique you use to guide you about placement of your electrolytes, particularly cations. So cations are positively charged. So what does PISO stand for? That's your potassium in, sodium out. So if this is your cell, the most abundant electrolyte inside the cell is your potassium, and the most abundant electrolyte is your sodium. Potassium in, sodium out. Okay. So having said that there is burn injury, so we say that there is exposure to extreme heat, correct? So because of the exposure to extreme heat, nasisira yung cell. Pag nasira yung cell, nasisira yung cell wall. Again, pag nasira yung cell wall, lalabas yung potassium from intra to extracellular. So lalabas yung potassium from intra to extracellular, from intra to extracellular. Tataas ngayon ang potassium sa blood. We call that condition as hyperkalemia. Okay, so why did the patient end up having hyperkalemia? Because of the cell injury causing release of potassium from the intracellular to extracellular. Simple as that. So cell lysis will result to release of potassium from intra to extracellular. This will cause a condition called hyperkalemia. Okay, this will result to a condition called hyperkalemia. Simple as that. Okay, now what will happen if a patient now has hyperkalemia? Hyperkalemia will result to, or it will increase the risks of cardiac arrest. Am I right? And this is the thing we have to prevent, cardiac arrest. Correct? Next, a patient with hyperkalemia, okay, may end up having what? Will end up having bradycardia, or a decrease in the heart rate. A decrease in the heart rate will result to decrease in your tissue perfusion. A decrease in the tissue perfusion will result to organ failure. And guess what? If there's cardiac arrest, if the heart ceases to beat, to contract, okay, cardiac arrest will result to decreased tissue perfusion. Okay, I hope that's clear. Mabilisan lang to na pathophysio. What about inhalation injury? Remember, we talk about carbon monoxide poisoning. We talk about carboxyhemoglobin. So inhalation injury can result to development of carboxyhemoglobin. And what did I tell you about carboxyhemoglobin? It decreases oxygen carrying ability of the blood. So the blood now is no longer sufficient, not sufficient, it's no longer efficient in carrying oxygen. As a result, that will decrease oxygen in the blood. We call that condition as hypoxemia. Hypoxemia, decreased oxygen in the blood, will result to decreased oxygen perfusion. Decreased oxygen perfusion again leads to decreased tissue perfusion, leading to organ failure. Okay, next. Break in the physical barrier. Remember your skin. What did it tell you about the skin? Skin is the first line of defense. Therefore, it increases the risk of infection. That is why your priority is admit the patient under protective isolation. And what else? The skin, you know this in your anatomy physiology. Oh, by the way, ano bang ginagamit yun na textbook sa anatomy? I can still remember when I was still a clinical instructor, I always recommend my students to have a copy of Anatomy Physiology authored by Marieb. I don't know why, I just fell in love with Marieb. I like how Marieb presents the topic. We have a lot of authors for anatomy physiology. By the way, if you have a good foundation with your anatomy physiology, hindi ka mahirapan sa med-surg. Let's go back. So a break in the physical barrier, remember that the skin is not just the first line of defense. Your skin is also important for thermoregulation. So that is why a break in the skin will cause altered thermoregulation. Altered thermoregulation. regulation. O, diba? Next, here, blood vessel wall injury. There's injury in the blood vessel because of heat exposure. Now, this is, in this part, I want you to pay attention, okay? Because it's quite tricky. Lagyan na lang natin dito. Remember, this is the blood vessel, okay? The plasma and the interstitial, okay? And then there is heat exposure. Heat exposure. And what did I tell you? Heat exposure can cause injury in the blood vessel wall. And remember, I said it increases blood vessel wall permeability, correct? So let's go back. Blood vessel wall injury can cause increased wall permeability. Permeability. So what will happen if the wall is permeable? Fluid gets out. Fluid gets out. So this will result to a condition called fluid shifting. And again, what is the movement of fluid during this scenario? The movement of fluid is plasma to interstitial, correct? Or intravascular to extravascular. Let's go back. When there is fluid shifting, okay, when there is fluid shifting, there are two conditions you need to remember. When fluid shifts, pag lumalabas yung fluid, ano ang kasama ng fluid na lalabas na electrolyte? Definitely the sodium. Sodium gets out. Okay, where water goes, sodium goes. So because of fluid shifting, sodium gets out from the vascular compartment. This will result to a condition called hyponatremia. Okay, so you have a highlight now. Patient with burn injury will have hyperkalemia on this phase and hypokalemia on this phase. Why did the patient develop hyperkalemia? Because of cell lysis, causing release of potassium from intra to extracellular. Why did the patient develop hyponatremia? Due to fluid shifting, secondary to increased wall permeability, secondary to blood vessel wall injury, secondary to heat exposure. Next, pag nagsisilabasan yung fluid, if you have fluid shifting, what will happen to your blood? The blood now loses water. The blood now loses fluid, making the blood what? Concentrated or diluted? Concentrated or diluted? Concentrated. Definitely. Very good. Congratulations. Okay, very good. Concentrated. So this will result to hemoconcentration. Hemoconcentration. Now, what specific test confirms that the blood is concentrated? Kung nakinig ka sa fluids and electrolytes ko na topic few weeks ago, you will answer this correctly. It's your hematocrit. So what will happen to your hematocrit if the blood is concentrated? It bumps up. It goes up. So if the blood is if the hematocrit is high, it means to say that the blood is concentrated. Okay, next. Because of fluid shifting, nagsisilabasan yung fluid, what will happen to your blood volume? It decreases. So fluid shifting will result to decrease in the patient's blood volume. And decreased blood volume, if not treated, will result to a condition called hypovolemic shock. Correct? Correct. The question here, what causes hypovolemic shock? The cause of hypovolemic shock is fluid shifting. What causes fluid shifting? Vessel injury. What causes blood vessel injury? Heat exposure, heat injury, burn injury. Therefore, you call this type of hypovolemic shock as burn shock. Okay, we just call it burn shock because the cause of this shock is burn injury. Now, here's the catch. A patient in a state of shock, a patient in a state of burn injury, burn shock will require massive stress response. The body needs to compensate. The body needs to react to that. Okay, so burn shock requires massive stress responses. Ibig sabihin, the body will react to that. It's a stressor. It's a stress. May tinatawag tayong stress adaptation. The body will compensate. The body will react to that. Why? It's a form of compensation. Okay? So, ano yung mga stress responses natin? Okay. Stress responses are the following. So, there will be stimulation Bagong lahat, burahin ko muna to. Okay, there is stimulation of adrenal gland. Stimulation of adrenal gland. And part of stress adaptation ay there will be increase in your catecholamines or your catecholamines. Now, what are those catecholamines or catecholamines? These are your epinephrine and norepinephrine. Okay? So what will happen now? Lagyan na lang natin dito. Okay. So pag na-stimulate ng adrenal gland, okay, particularly the adrenal cortex, okay, the adrenal cortex, it stimulates the adrenal cortex. Adrenal cortex. By the way, the adrenal cortex is the outer part of your adrenal gland. Remember, the inner part of your adrenal gland is your adrenal medulla. Your adrenal gland can be found on top of each kidney. So we have two kidneys, so technically we have two adrenal glands. Since adrenal glands can be found on top of each kidney, you also call adrenal gland as your suprarenal gland. Anyway, so once adrenal gland, particularly the adrenal cortex, is stimulated, it releases a hormone called cortisol. Okay? Another name of cortisol is glucocorticoid. Glucocorticoid. Okay, sa mga estudyante ko, you know this, okay, you know the technique. Remember, it affects the glucose. It affects the glucose. When the cortisol is high, when the glucocorticoid is high, it increases the sugar. So it causes hyperglycemia. So therefore, this is a highlight in your examination. A patient with burn injury, okay, a patient with burn injury on the first, let's say on the first 13 hours, when you check the blood sugar of the patient, the sugar is high. The patient is hyperglycemic. Why is the patient hyperglycemic in a burn injury? It's a form of stress adaptation. It's a form of what we call stress response. Will you notify the doctor? No, just document that. Why? Because that is expected. Okay? So don't forget that. Hyperglycemia. Okay? Next, another thing. A patient with massive stress response, okay, stress responses, I mentioned this, it will also increase patient's basal metabolic rates. Remember, there's increase in your metabolic response. So I mentioned this will increase the risk of your metabolic acid production, and then it will also increase patient's hydrochloric acid production, leading to high risks of peptic ulcer disease, PUD. What specific PUD here? It's your stress ulcer. Again, what is another name of stress ulcer? Curling's ulcer. Next. Dito na lang. Shortcut na lang natin. Wala na akong space. Remember, there is release of catecholamines or catecholamines. Epinephrine, norepinephrine can cause what? Vasoconstriction or vasodilation? Tell me. Epinephrine, norepinephrine can cause what? Vasoconstriction, vasodilation. Vasoconstriction. Correct. Very good, Mr. Rickeforth. That is vasoconstriction. Vasoconstriction. Okay, when the blood vessels constrict, what will happen? When the blood vessels constrict, it will impede normal flow of blood, okay, and that will result to tissue injury. And guess what? If there is infection, if there's altered thermoregulation, this will also lead to tissue injury. Ano ba yan? Palitan natin. Okay, next. Catecholamines, okay, we have your epinephrine, norepinephrine. What will happen is that it increases patient's heart rate, correct? An increase in the heart rate. What will happen if you have a sustained tachycardia? An increase in the heart rate will result to decrease in the cardiac output. Am I right? Sir, bakit sir? Di ba? Ganito yan. Pag masyadong mabilis ang blood volume, pag masyadong mabilis ang nagsasabi ko, pag masyadong mabilis May nagtanong dito, sir, meron po ba kayong lecture about Parkinson's disease? Meron po. Meron po. Okay? Check mo na lang sa na-upload ko na videos. Ano yung sasabihin ko? Nakalimutan ko tuloy. Ano nga yun? Cardiac output. Okay. So, pag mabilis ang tibok ng puso, if you're tachycardic, a sustained tachycardia, pag mabilis ang tibok ng puso, hindi pa napuno ang heart ng dugo, nag-contract na kaagad. So as a result, pag hindi pa siya napuno at nag-contract na, decrease ang ventricular filling. So anong ilalabas na blood? Decrease. So decrease cardiac output. Okay? I hope that is clear. So increased heart rate will result to decreased cardiac output, okay, resulting to decrease in your tissue perfusion. Decreased tissue perfusion will lead to organ failure. Ayan. O, diba? Na-connect natin sila. Okay? Ito yung mga pinakamadaling explanation na lang para madali yung maintindihan. I don't know kung naintindihan nyo. Okay? So, this is what we called a major burn injury problem. Okay? Now, let's go back to your examination. I'll clear the board. Now, in your examination, don't forget that burn injury has several stages. Okay? Isa ito sa pinaka-highlight ng or common na lumalabas sa exam. Stages of burns. Stages of burns. There are actually, there are 4 stages. Ano ba yan? There are 4 stages. Okay. The first stage of burn injury is what we call emergent phase. Emergent phase. Okay. This phase refers to actual exposure to extreme heat. Okay. It refers to there is actual exposure to the heat source. The second stage of burn injury is what we call your shock phase. Okay. We call it shock phase because this is the phase where shock is very common. Therefore, if you will be asked what's your priority here, your priority is to prevent shock. Anong dapat tandaan sa exam? Kailan lumalabas ang shock phase? So shock phase occurs, okay, it occurs on the first 24 to 48 hours. Okay? It occurs on the first 24 to 48 hours. So if you'll be asked what's your priority on the first 24 hours, the answer will be prevention of shock. How will you prevent shock? Fluid resuscitation. Correct? So what is the thing you need to remember here? Your fluid shifting. You need to understand the movement of your fluid. Okay? Fluid shifting on the first 24 to 48 hours is plasma to interstitial. This is the thing you need to remember in your exam. Okay? Pag naintindihan mo na ang movement ay plasma to interstitial, kahit nakapikit ka sa select all that apply, you'll be able to select the correct options. The common question here will be select all that apply the different fluids and electrolyte imbalances on the first 24 to 48 hours. Remember, if this is your blood vessel, plasma here, interstitial outside. Nagsisilabasan yung fluid from plasma to interstitial. So having said that, ano kaya ang possible fluids and electrolyte imbalances? Letter A, nagsisilabasan yung fluid, this will result to hypovolemia. And hypovolemia is represented as a decrease in your CVP. Remember, a decrease in the CVP would indicate hypovolemia. Letter C. Kung nagsisilabasan yung fluid, what will happen to your blood? Nabanggit na natin, concentrated. So you will have hemoconcentration as evidenced by an increase in the hematocrit. Letter D. Pag nagsisilabasan yung fluid, ano ang kasama niya na electrolyte na lalabas? Nabanggit na natin kanina, hyponatremia. Kaka-expose na lang sa heat, nasira yung cell lysis, hyperkalemia. Am I right? Next, letter F. Sir, decrease ang blood volume, decrease ang perfusion sa kidneys. This will result to decrease renal perfusion. As a result, that decreases patient's urine output. Correct? A decrease in the urine output will result to increased BUN and increased creatinine. Am I right? Tama, Sir John. Next, letter H, increase in your metabolic response. So patient may have metabolic acidosis. So please do not forget this in your NCLEX examination, particularly select all that apply. So lumalabas ito on the first 24 to 48 hours because the movement is plasma to interstitial. So remember, shock if not treated. Hypovolemia can result to hypovolemic shock if not treated. So what's your goal here? Prevention of shock. How? We do fluid therapy. After that, here comes the third stage of burn injury, and we call that as your diuretic phase. Okay? Now, if shock phase occurs on the first 24 to 48 hours, ang tanong naman sa diuretic phase, kailan siya lumalabas? Diuretic phase occurs when 2 to 5 days post-burn injury. Okay, take note 2 to 5 days post-burn injury. And again, what will be the fluid shifting during this time? Baliktad. The fluid shifting is interstitial to plasma. Ibig sabihin, yung lumabas kanina na fluid, okay, plasma, interstitial, babalik siya ngayon sa ugat. Okay? So magsisibalikan yung tubig inside the vascular compartment. Magsisibalikan sila kung saan sila galing. Having said that, magsisibalikan sila kung saan sila galing, another name of your diuretic phase is fluid remobilization phase. Okay? Don't forget that. Diuretic phase, fluid remobilization phase ay iisa lang. So, kung ang movement ng fluid ngayon ay interstitial to plasma, again, in your NCLEX exam, what are the different fluids and electrolyte imbalances? Okay, letter A. Sir, nagsisibalikan yung fluid. So that will increase the blood volume. That will result to hypervolemia, as evidenced by what? An increase in your CVP. Correct? Sir, nagsisibalikan yung fluid. So what will happen to your blood now? Concentrated, diluted? Syempre, diluted. Hello? So you will have hemodilution, as evidenced by what? A decrease in the patient's hematocrit. Remember, kung nagsisibalikan yung fluid inside the vascular compartment at ang blood ay diluted, malabnaw, what will happen to sodium level? High or low? Low. So you will have hyponatremia. Okay? So sir, balikan natin. So hyponatremia dito, yes. Do they have the same cause? No. So understand this. The cause of hyponatremia during shock phase, okay, this is due to fluid shifting. Ano naman ang cause ng hyponatremia sa diuretic phase? This is due to hemodilution. Ibig sabihin, sa sobrang dami ng tubig sa ugat, natunaw ng tubig yung ugat. In short, we can say that there is water toxicity. Okay? Next, letter E. Sir, nagsisibalikan ngayon yung tubig sa loob ng ugat. Ganon din po yung potassium na nakalabas kanina sa cell lysis. Babalik din sila ngayon sa loob ng cell. So kung babalik din yung potassium inside the cell, this will result to hypokalemia. Okay, so again, what causes hypokalemia? Okay, on 2 to 5 days post-burn. Related to what? Return of potassium inside the cell. Okay, remember, potassium is an intracellular electrolyte. Next, letter F. Alam nyo, napakanta pa, A, B, C, D, E, F, E, F, F yung sunod. Okay? Ganon din ba kayo pa nagsusulat kayo ng mga letters, kinakanta nyo? Anyway. Next, sir, increase ang blood volume. So an increase in the blood volume will result to increase in your renal perfusion. Increase in the renal perfusion resulting to an increase in the patient's urine output. Can you follow? So ihi ka ng ihi ka ng ihi. Kaya ang tawag diuretic phase. Oh, that makes sense now. So ihi ka ng ihi ka ng ihi. Magbababa na ngayon ang iyong BUN at creatinine. Sisimula na silang bababa. Okay, it starts to decrease. And of course, but still, they have an injury, you may still have some metabolic acidosis. Metabolic acidosis. Until such time you have the fourth stage of burn injury, and you call this as your rehabilitation phase. Other book, they don't call this rehabilitation phase. Other book, they call this as recovery phase. Recovery phase. Okay? So tanong, kailan magsisimula ang rehabilitation phase or recovery phase? Okay? This phase occurs when diuresis is completed. Magsisimula ang rehab phase if tapos na ang diuretic phase. So kailan siya matapos? Depende po sa extent ng injury, depende po sa fluid shifting. Okay? I hope this is clear. Anyway, let's check if you have questions. Ito may nagtanong. Yes sir, klaro na no. Ano daw? Lala Maagad. Good afternoon sir. Good afternoon. Risa Bastila, thank you sir. Saan po siya na-upload? Wala po kasi siya dito sa YouTube. Nasa YouPorn. Sorry, Risa. Andito sa nasa YouTube ko pala nanonood ngayon. Nasa Facebook. Nakastream din ako sa Facebook simultaneously. So, Risa, please send a message to me privately sa Facebook. Pag hindi mo makita, let me know and I will give you a copy. Okay? Bilisan nyo guys ang pagpasa ng NCLEX. Ano ba? Anyway, who do we have here? Hello to... Let me check. Sino ba nandito? Hello to Red Kapuyan. Hi Sir Red, kumusta? Lizelle, hi there. Raul Gambalan. Hi Sir Raul. Ito pa si Raul. Attending and listening to your lecture, Surgeon, is a music to my ears. Ganon! Way back our NLE preparations, the same as magbugno ang mga NLE reviewers, takers, o kuha og seat sa among section. Kaya naa ka dito nag-lecture. Mabuhay ka, sir. Oo nga, ano, kaya nga I'm so happy that andyan pa rin kayo. Okay? Karen Alagasi, hi. Queenie Grace T, hello there. Ana Claire Suelto. Gemma Pronoble, hi there. Janry Ryan, hello. Ciel Tagotongan. And Ma'am Cleofe de Los Santos. Hi, Ma'am Cleofe. Ma'am Cleofe sa CIN. CIN ng nursing at saka midwifery. Hello, Lizzie Treasy. Hello, watching from California. Hi, how's everybody there in California? By the way, I'm going to California third week of March. Okay. Hindi pa pala mauuna. Yeah, third week of March. Yeah, third week of March. Kasi I'm leaving, currently I'm in Minneapolis. I'm driving to Yellowstone first or second week of March. I'll stay there for a couple of days. And then from Yellowstone, I'll be driving to Las Vegas. And from Las Vegas, I'll stay there for a couple of days and going to California after that. Hope to see you there. Let's go back. Okay, so these are the different stages of burn injury. Okay, ito yung mga highlights sa NCLEX, ito yung mga fluids and electrolytes imbalances na to. Please do not forget them. Okay, so let's proceed. Now, who do we have here? Arde Arj Namok Agawin, Gapaminaw while working. Thank you, sir. Oh, ganun talaga. Hello to Gemma Pronoble. Hi, nakikinig po dito from New Lucena, Iloilo. Bara kayo mo yan sa Iloilo, ya. Baka layo sa imo, ha? Mas layo ko no? Baka nahidlaw na ko sa inyo sa Iloilo ba? I have a good memories there. Anyway, let's go back. So, isa po sa mga management ng pasyenteng may burn injury is your fluid therapy. Okay? So, you have your fluid resuscitation. Resuscitation. Okay? So, when you say fluid resuscitation, there are different um, ways to resuscitate patient. We have here the Parkland formula. Parkland formula. We have Brooks formula. We have modified Brooks formula. We have hypertonic formula. So ang dami, no? Lahat naman sila effective. Lahat sila pwedeng gamitin. Meron pa tayo dito. Anna Claire Gadoswelto, listening from Saudi Arabia, sir. Bag-orak naka-out. So, kasalanan ko pa ngayon, ha? Anyway, thank you so much. Ingat kayo dyan sa Saudi Arabia, okay? Anyway, here, Karen Alagasi, sir, I miss your pathophysia way back in SPC times. Oh my God, labaw na sa duties award. Mo-appeal ko dali, sir. Yeah, sure. Yeah, my God. Why are you here? Mga estudyante ko dati. But anyway, for the information, I used to be a clinical instructor. So nursing for how many years was that? Almost 5 years. I handled their pathophysiology, pharmacology, medical surgical nursing, and anatomy physiology. Because those were the days. Anyway, so these are the different ways how to resuscitate patient with burn injury, specifically major burn. Okay? So we use Parkland formula, Brooks formula, modified Brooks, hypertonic. Actually, marami pa. But the commonly used is the Parkland formula. Okay, so we'll talk about Parkland. Parkland formula. By the way, there is another name of Parkland formula. You also call this as your Baxter formula. Baxter. Okay, Baxter. So when you say Parkland formula, okay, don't forget that this is actually used when on the first 24 hours. Okay? And, okay, don't forget that the solution used for Parkland formula is plain LR. Plain LR. Okay? In Parkland formula, we use a plain LR, lactated ringer solution. And we use this on the first 24 hours. And what's the formula, Sir John? What's the formula? The formula is 4 ml times weight in kilograms times TBSA. Okay, this is the formula. 4 is constant. So take note, weight must be in kilograms. So if they use pounds, you have to convert that pounds to kilogram. Okay? And TBSA. Ito yung sinasabi ko kanina, make it sure that you have to compute the TBSA correctly. Mali na yung computation ng TBSA, mali na yung Parkland formula. So how do we do fluid resuscitation using Parkland? Ito yung kanyang distribution. 50% of total fluid volume is given, okay, given on the first 8 hours. Given on the first 8 hours. The remaining 50% of the total, okay, of the total fluid volume is given over the next 16 hours. Okay? So 8 plus 16, that will give you a total of 24 hours. Ibig sabihin, whatever is the product of your Parkland formula computation, 50% of that total fluid is given on the first 8 hours. And the remaining 50% is given over the next 16 hours. Okay? Sir John, can you give us an example? Sure. Let me give an example. Let's say, sino ba dito nandito sa last ko? Simon, ito si Simon. Simon, let's say Simon is 31 years old. Okay? And Simon's weight, okay, weighs, let's say 165 pounds. Okay? And sustained the following burn injury site. Okay? Simon sustained burn injury on the following sites. Okay, here, see how the right upper extremity, left anterior upper extremity, abdomen, and let's say posterior lower extremities. Okay, let's try to compute. Okay, how many percent TBSA? Sige nga. Okay, right upper extremity. How many percent is this? Right upper extremity. Right upper extremity. This is 9%. Left anterior upper extremity. Left anterior upper extremity. This is 4.5. Abdomen. This is 9. Okay? Because if it's anterior trunk, that's 18. Right? That's 18. But it's only the abdominal area, so that will give us 9%. Posterior lower extremities. This will give us 18%. Okay? Am I right? Hello to my batchmate, Julian Garcia. So, you try to add natin, tsaka i-compute natin yung ano. I hope you got it correctly. Where is that? Utilities. Okay. So you have 9 plus 4.5 plus 9 plus 18. So that will give you 40.5. Okay. So this is a total of 40.5. Okay. 40.5. And what about 165 pounds? 165 divided by 2.2. So this is actually 75 kilograms. Okay, nasan ka na? So this is equivalent to 75 kilograms. Am I right? Okay. So using the Parton formula, so we have 4 ml times weight in kilograms times 75 times, what is a TBSA? 40.5. Okay? By the way, yung 40.5, minsan sir, nalilito ko sir, is 40.5%. So dapat i-move ko siya ng decimal places into 2 to make it a whole number. No, 40.5 pa rin. Okay? So let's try to multiply now. So 4 times 75 times 40.5. So the product will be 12,150 ml. Ito po yung kabuuan na ibibigay natin for 24 hours. Kaya lang, 50% of this is given on the first 8 hours. The remaining 50% is given over the next 16 hours. So to get the 50% of this, you divide this into 2. Okay, divide it into 2. So if you divide it into 2, the quotient will be 6,075 ml. Am I right? 6,075 ml is the 50%. So ang tanong, kung ibibigay mo ito sa first 8 hours, how many ml per hour will you give on the first 8 hours. Madali lang. So ang gagawin mo ay 6,075 divided by 8. Okay? Divided by 8. So that will be 759.3 ml per hour on the first 8 hours. Can you follow? Pero ito naman, given over the 16 hours, 6,075 ml divided by what? 16. So how many ml per hour will you give that? So divide mo lang yan, okay? So 6,075 divided by 16. So that will be 379.6 ml per hour. Okay? So that's how you're going to answer that your examination. And one more thing. Pag hindi sinabi sa examination, convert your answer to the nearest whole number. Do not convert. Pag sinabing convert, dun ka lang mag-convert. Okay? I hope that is clear. So take note, 50% of this is given on the first 8 hours. Remaining 50% is given over the next 16. So this will complete the 24-hour fluid therapy. Okay? Here, what do we have here? Raquel de Castro, example po, please, Parkland. Tapos na, yun na nga, oh. Okay? Okay. Do you have any questions? What do we have here? Okay. I hope that that's clear, guys. I hope you learned something. So I think that's all. Actually, marami pa yung treatment, yung mga compartment syndrome treatment natin, escharotomy, hydrotherapy, yung gamit yung whirlpool, but dinidiscuss ko yan sa actual na review. But I gave you almost 80% of the highlights for the NCLEX examination when you talk about burn injury. Okay? So please don't forget those. If you have any questions, let me know. May mga tanong pa po kayo? Anything you want to ask? Okay. I think wala nang tanong. Thank you so much, guys. If you stayed this long, thank you so much for staying. I hope you learned something. I wish you luck in whatever qualifying examination you're planning to take in the future. Okay? And please drop a message if you want me to discuss any topic about medical surgical nursing, and I'll be glad to share what I learned. Okay? So I think that's all. What time is it? It's 1:10 in the morning. So technically, it's almost 3 o'clock ng hapon sa Pilipinas. Jean Diana said, thank you. Welcome po. Mary Fee Woodward, thank you, sir. Till next YouTube live. Yeah, sure. Actually, nakasync to eh. Simultaneous ako nagla-live. YouTube, Facebook, page. Basta 4 yan. Hi to Darlene, May, Capin, Abon. Hi there. How are you guys? And do you have any questions? Actually, hindi pa ako inaantok. Gusto ko pa nga mag-discuss pero hindi ko alam kung ano pang i-discuss ko. Hello to Chris Morano. Hi there. 3 hearts talaga yon. Thank you so much for that. That's so sweet. Watching from, that's UAE, right? United Arab Emirates ba yan? Bobo ako sa flag. UAE ba yan, Chris? Oh, tama. Chris, are you working as a nurse there sa UAE? Riza Basila, thank you sir. God bless you. Sure. Hello to Rax D. Castro. Okay. Chris, ano yung mga common na mga sakit na na-encounter nyo dyan? And sa'yo din, Riza, ano yung mga common na mga sakit na na-encounter nyo? Naka-notify talaga sa YouTube. Well, thank you so much for following me, Marifi Woodward. Sir, dental po, oral surgery department po ako, sir. Okay. What about you? What about you, Riza? Okay, hello. Other questions, guys, or any topic? Wala na? Okay. Kung wala, I think we're good. So let's go. We have here. Hold on. Hello to Lala Maagag. Hi there. Sorry, ngayon ko lang nabasa yung message mo. Nasa ibang website ka kasi. Anyway, I think that's all, guys. Thank you so much for watching. Thank you so much for staying here. Sir, sa dentistry ako ngayon. Planong to take exam next month. My second attempt. Oh, okay, Riza. Planning. It's okay. So good luck, no? Good luck, and I hope that you will pass the NCLEX this time. Ano ba yung mga topic na nahirapan kayo, Riza? What topic you find it very hard? Hello to Sean Blazer. Thank you sa mga free NCLEX videos. Malaking tulong po. Welcome, sir. Sean, do you have any topic in mind that you want us to discuss? You want me to discuss? Oh my God. Nagulat ako. Akala ko may nagsasalita na iba. Rax commented on your... Hold on, may nag-comment. Bongga. Listening from Saudi Arabia. Ito talaga si Ian. Hello, friend. Wala kang magawa sa buhay. Alagaan mo yung mga pasyente mo dyan. Ano ba sabi niya sa akin? I-discuss ko doon yung mga monocot and dicot, mga cotyledon. Oh my God. ECG on ko, na-discuss ko na yan. Please check na lang the video. Monocot and dicot, cotyledons. Wala kang magawa sa buhay, friend, ha? Si Ian John, he's a friend of mine, and then coach din yan siya sa NCLEX. Kasama ko rin yan siya na lecturer. Currently, nasa work siya ngayon, night shift. Ewan ko ba't siya nanonood ng live ko? Di ba may trabaho ka? You have to work. You're being paid to work. Ha ha ha. Ano to? May tanong si Sir Ian. Sabi niya, ha ha ha. Discuss mo po bakit kahit 96% sat ng patient, bakit nag-a-alarm pa din ang machine? Friend, there's a lot. Na-discuss ko na yung alarm ng McVent, okay? Friend, hindi ka nakikinig ng lecture ko the other day. Na-discuss ko na yan. Here, Parkinson's disease, multiple sclerosis, at problem regarding cardiac po. So, okay, let's talk about Parkinson's disease. Oh my God, so dapat pala hindi yung title ko dito, anything under the sun. Pharmacology. My God, ganun, dami nagsasuggest ko nung topic. Wait, ito muna, kasi nakausap ko na si Riza. Anong cardiac case? Anong cardiac case? Anong cardiac case? Riza, I'm waiting. What specific cardiac case? Kasi ang dami nating cardiac cases, right? Ito, CHF, ano daw yun? Sabi ni Rax B. Castro, CHF and MI. Okay, sige, we'll talk about those concepts. Okay, patayin muna natin yung background. Alto light stream. I need to have my whiteboard. Check ko muna para makita ko yung aking just making sure that I can see all the messages. Okay, so let's talk about Parkinson's disease. Parkinson's disease. Okay, so what is Parkinson's disease? Parkinson's disease is a slowly progressive neurologic movement disorder, okay, due to a decrease in a neurotransmitter called dopamine. Yun yung definition niya. It is a slowly progressive neurologic movement disorder, okay, due to, okay, a decrease in a neurotransmitter. Ano ba yan? Neurotransmitter. Okay? Called dopamine. Okay? Himay-himayin natin ha. So what is Parkinson's disease? Parkinson's disease is a slowly progressive. Okay? Slowly, it occurs gradual. Progressive, lumalala. Neurologic movement, it affects motor functioning. Kasi mababa daw ang level ng neurotransmitter na ang tawag ng neurotransmitter na yon ay dopamine. Okay? So technically, when you say Parkinson's disease, it is a form of what? It is a form of degenerative brain problem. Kasi nga progressive, lumalala, nagpo-progress. So it is a form of degenerative disease. Okay? So Parkinson's is a form of degenerative problem. So tandaan nyo lang sa exam that pag sinabi kong degenerative, kanino common yan? Common po ang degenerative to men than in women. Ang common sa mga babae ay autoimmune. Okay? So again, slowly progressive neurologic movement disorder due to a decrease in the neurotransmitter called dopamine. Now let's talk about dopamine. Okay, sir, pag sinabi kong dopamine, dopamine is what? Inhibitory, excitatory, both. Dopamine is inhibitory, and also excitatory. Okay? So, ano yung relevance niyan, inhibitory, excitatory? If you can still remember, ang acetylcholine is excitatory sa muscles. Okay? Excitatory sa muscles, inhibitory sa, what do you call this? Inhibitory sa neuro. It's the total opposite of your dopamine. Okay? So dopamine is actually inhibitory for neuro, excitatory for the muscles. Okay? So ibig sabihin, kung wala kang dopamine, hold on. Baka baliktad. Acetylcholine is excitatory. Baliktad. Okay, inhibitory. Hold on, saglit lang. Dopamine. Give me a few minutes. Baka mali yung masabi ko. Yan. That's the correct way. That's the correct description. Dopamine is inhibitory to your muscles and excitatory to neuro. Okay? Now, itong dapat tandaan na meron tayong isang kondisyon na pag masyadong mataas ang dopamine, it gives a specific problem. Okay? I want you to see this scenario. Ang Parkinson's disease, mababa ang dopamine. Kung mababa ang dopamine, walang mag-inhibit sa muscles. Correct? Kaya kung walang mag-inhibit sa muscles, you will have tremors. Okay? May condition po tayo na mataas ang dopamine. Okay? Pag mataas ang dopamine, you call that condition as your schizophrenia. Am I right? Kaya nga, pag mataas ang dopamine, excited ang mga neuro, you will have a condition called schizophrenia. Anong gamot? Okay, wait lang ha. Decreased dopamine is your Parkinson's disease. Pag ang patient po ay may schizophrenia, ang binibigay natin na gamot is antipsychotic med. Am I right? So what we give here is antipsychotic. Therefore, kung magbigay ka ng antipsychotic, the main goal there is to decrease the dopamine. Am I right? Therefore, if you give antipsychotic at bababa ang dopamine, you will have what? Parkinson's. Kaya nga, patient with schizophrenia taking antipsychotic, you need to watch out for pseudo-Parkinsonism. Okay? Samantala, ang Parkinson's disease, mababa ang dopamine. So what we give here is an anti-Parkinsonian drug, just like your what? Levodopa. So pag nagbibigay ka ng anti-Parkinsonian drug, okay, it will bump the dopamine. You need to watch out for what? Psychosis. This is the thing I want to drive. Okay? Okay, I hope this is clear. Now, let's go back. Sir, bakit po bumaba ang level ng dopamine? What do you think is the cause of Parkinson's? The cause of Parkinson's is actually unknown, okay? But research study shows that this is related to damage or injury of your substantia nigra cells. Okay? What causes damage or injury to your substantia nigra cells that can cause production for dopamine? Unknown. Okay? I said this is common to men than in women. Because of a decrease in the dopamine level, lalabas yung triad symptoms. Okay? Triad symptoms. Number 1. Sa pag-triad, syempre tatlo yun. Am I right? What are those triad symptoms? Okay, number 1, patient here will have resting tremors. Resting tremors. Sir, tanong, pag sinabi kong resting tremors, okay, yan ba yung earliest presentation ng patient? Yes. Resting tremors is actually one of the earliest presentation. Okay? And what else? Yung resting tremors ng pasyente, evident, okay, when at rest. Okay? Ibig sabihin, if the patient moves, gumagalaw yung pasyente, hindi masyado prominent yung tremors. But if the patient is at rest, dun lumalabas yung tremors. Kaya ang tawag resting tremors. Different siya sa intentional tremors na lumalabas sa pasyente may multiple sclerosis. Okay? I will explain that in a bit. And the resting tremors are actually aggravated by stress. Aggravated by stress. At saan yung common sites ng resting tremors? Saan yung common sites ng resting tremors? It may affect the head of the patient. It may affect hands of the patient. The head of the patient, pag may tremors, will move side to side. Side to side. And then, yung hands ng patient will have a characteristic of pill rolling. Okay? Expound. So the head of the patient will move side to side. Ayan, may demonstration talaga. No? The hand of the patient will have pill rolling. Okay? Pill rolling. So take note that. Ako yung tatayo talaga, magda-demonstrate. Oh my God. Pinadiscuss nyo talaga ako. So, let me see. I just hope ang galing ko pala to. Ayan. So, for example, I'm the patient. Okay? So, I am the patient with Parkinson's disease. Meron pa dito. Sean, sir, can you discuss advanced directives, special power of authority, and R in the US? Yeah, sure. We can do that. Here. So, I am the patient with Parkinson's disease. Pag gumagalaw yung pasyente, hindi common yung tremors. But if the patient is at rest, dun lumalabas yung tremors ng patient. Again, head will move from side to side. Hand will have pill rolling. Ganon. O, diba? And what else? Take note, lumalabas din yung tremors if the patient is awake. Okay? If the patient is awake. Okay? Next. The second triad symptom is that the patient will have bradykinesia. Bradykinesia. Nasaan na yung aking whiteboard? Bradykinesia. Second, yun natin isasulat. Bradykinesia. Bradykinesia. So what do you mean when you say bradykinesia? It refers to slow movement. Okay. What else? Patient will have loss of normal arm swing while walking. Pag naglalakad siya. There is also apathy. Diba nakakaloka? There is also decreased patience. Ano ba yan? Blinking reflex. Decrease blinking reflex. And because of bradykinesia, patient will have a mask-like face. Or we call that poker face. Ayan. Poker. Poker face. Okay, balikan natin ha. So yung patient po na may bradykinesia, saan yung aking ano? Tanggalin natin. Balikan na naman natin. Yung patient po na may bradykinesia, apathy. Parang wala siyang reaction, wala siyang feelings. Decreased blinking reflex. Mask-like face or mask face. Hindi siya pwedeng baliktarin, face mask, hindi po, mask-like face or poker face. Normally, pag naglalakad tayo, our arms will swing. Correct? Our arms will swing. Naglalakad tayo. Normally po, when we walk, arms will swing. But patient with Parkinson's, okay, there is loss of normal arm swing while walking. Okay? Loss of normal arm swing while walking. Okay? What else? Third, there is muscle rigidity. Nasaan na yung whiteboard? Whiteboard. Third, there is what we call muscle rigidity. Okay? Because of muscle rigidity, patient will have this what they call increased resistance. Increased resistance to passive movement. To passive. Wait lang, baka may tanong dito. Sir, pa-screenshot ng board after lecture. Okay. Passive, increased resistance to passive movement. And because of muscle rigidity, patient will have cog-wheeling. Okay? So these are the triad symptoms. Discuss mo natin muscle rigidity. Paano ba yan? Ang hirap ano, pag hindi ko, mas gusto ko kasi pinapakita yung may, normally when you, paano ba yan? Dang. Hey, nawala yung aking monitor. Yung aking second screen, nawala. Bad. Anyway, normally kasi, di ba, pag uupo tayo, walang resistance. Ang patient na may Parkinson's, may resistance siya uupo. Pag may pumipigil sa kanya, may resistance. So having said that, ano kaya yung mga possible questions sa NCLEX having said all those triad symptoms? Priority will be safety of your patient. Okay? Because of resistance when the patient sits down, because sitting is a form of passive movement, make it sure that the patient with Parkinson's disease, you need to provide an elevated chair. Okay? Elevated commode. Okay? Because of what we call resistance. Ano ba to? Bakit yung ating? Dalawa kasi monitor ko, ano? Isang malaking monitor at saka yung laptop. Ngayon dito na ako sa laptop nakatingin. Okay? Now, apart from that, ano pa yung mga other presentations ng patient? Oh, screenshot mo na. Okay, let's proceed. So apart from that, other manifestations of your patient will have drooling. Okay, patient will drool. Okay, their patient will have a stoop posture. Okay, patient with, matanong ba dito? Kita ka po sa front namin. Kagwiling, paano yan? Oh yeah, tama, kagwiling. Paano ba yan? Ito na lang ha. Yan na lang. Saglit lang. Oh my God, pinahirapan niyo talaga ako, ano? I am watching through my phone so that I know if I'm on the right angle. Okay. May balikbayan box ako dito. Pinupuno ko yan. So, normally, okay, I don't know if you can hear me well. So, normally when we walk, normal arm swing, correct? Normal arm swing. The patient with Parkinson's, their stoop posture, okay? Patient will drool, mask-like face, decreased blinking reflex, correct? Okay, at rest, patient's head will have pill rolling, head will move side to side, correct? When the patient starts to move now and starts to walk, the tremors will gradually disappear or will decrease. And take note, loss of normal arm swing while walking, and when the patient walks, cartwheeling. Oh my God, nakita niyo yun? Nakita niyo yun? Ulitin ko ah. Patients at rest, when the patient walks, loss of normal arm swing while walking, okay? Decrease ang tremors ng patient, cartwheeling. Ganun yun, okay? Pinahirapan ako. Okay. I need to have my second monitor on. Anyway, here. Okay, stoop posture. Patient will have a shuffle gait. Okay, because of shuffle gait, don't forget this in your examination. Tell the patient to look straight forward. Okay, shuffle gait, because of shuffle gait, tell your patient to look straight forward. Okay, patient will also have micrographia. Patient may have microphonia. What is micrographia? Micrographia means when the patient, sorry, hindi niyo pala nakikita. Sulat ako ng sulat, hindi nakikita. Oh my God, where is that? Here. So shuffle gait, I said shuffle gait, tell the patient to look straight forward. Micrographia, microphonia. What is micrographia? Micrographia means when the patient writes, his penmanship gets progressively smaller. Okay? There, bumalik niya aking monitor. Okay, micrographia means when the patient writes, his penmanship gets progressively smaller. Microphonia, on the other hand, is different. Microphonia means when the patient talks, his voice gets progressively smaller. Okay? His voice gets progressively smaller. His voice gets progressively smaller. Okay? Now, those are common presentations of your patient. Now, do we have a specific laboratory test for Parkinson's? There is no specific laboratory test, but there is one test. Okay, there is one test very helpful in diagnosing patient with Parkinson's, and that is your PET scan. your PET scan. Now, what does PET scan stand for? PET scan stands for positron emission tomography. Positron emission tomography. Now, what can be seen in your PET scan is that there is a decrease in the level of your levodopa. Sir, bakit levodopa? Akala ko ba pinag-uusapan natin yung dopamine? I know, but remember, levodopa is a precursor of your dopamine. Okay? So that's it, a decrease in your levodopa. Are you with me? Now, there is no specific cure for your Parkinson's. Okay, remember this is a form of degenerative problem. Okay? So ano yung mga common na gamot na binibigay natin sa pasyente? So we give here anti-Parkinsonian drug in a form of your levodopa. Okay? Now tandaan, your levodopa and anti-Parkinsonian, may mga tanong ba dito? Sa kabila. Usually, levodopa is effective, okay, during the early phase of treatment. On the later part, hindi na masyado nagre-respond yung pasyente. Usually, you have to increase the dose of your levodopa. And take note, the levodopa must be given with carbidopa. Carbidopa. Given with carbidopa. So why do you have to give this with carbidopa? Why do you have to give this with carbidopa? Kasi ganito yan. Pag levodopa lang iinumin mo at na-absorb ng katawan, it enters the bloodstream. Okay? If it enters the bloodstream, the blood enzymes will break down the levodopa. So no enough levodopa can get inside the brain. So what are you going to do here is you mix levodopa with carbidopa. The purpose of your carbidopa is to prevent breakdown of your levodopa. Okay? So the main reason why we give carbidopa is to prevent breakdown of levodopa. Pag pinag-combine mo yung levodopa at carbidopa, ang tawag natin dun Captain Planet. No. Pag pinag-combine natin ang levodopa at carbidopa, we call that Cinemet. Okay? So we given with carbidopa. So we call that levodopa plus carbidopa equals Cinemet. I hope this is clear. Next, wag kalimutan sa exam. If your patient takes levodopa, you have to decrease what specific vitamin? Vitamin B6. This is your pyridoxine. Remember, why do you have to decrease B6? Because again, vitamin B6 will what? Decrease the absorption of your levodopa. Your pyridoxine will decrease absorption. So tandaan yun ha, if your patient, you have to decrease vitamin B6. Pero remember, may gamot tayo na pag binibigay, you have to increase vitamin B6, right? Can you recall that? Anong gamot na pag iniinom mo, you have to decrease vitamin B6? It's your levodopa. Anong gamot pag iniinom mo, you increase B6? It's your INH, which is a form of an anti-tuberculosis. Diba? So ito yung technique mo. L, levodopa, L, low B6. INH, I, increase B6. Balikan natin. Why will you decrease vitamin B6 for patient taking levodopa? Because I said vitamin B6 will decrease absorption of the levodopa. Why will you increase vitamin B6 to patient taking INH? Remember, we know this by heart. Mga Filipino nurses, dapat alam natin yung anti-TB drug kasi common yung TB sa Pilipinas. Diba? So alam natin yung RIPES. Dapat alam nyo bakit pinibigay ang vitamin B6 sa mga pasyenteng umiinom ng INH to prevent peripheral neuritis. Diba? Hello? Okay, that's very basic. Remember, RIPES, rifampicin, INH, PZA, ethambutol, streptomycin. Anyway, so that's it. That's your levodopa. Okay? Clear? Meron pa tayong mga ibang mga gamot na binibigay. Yung mga MAWI, you give antiviral. Okay? But I just want to discuss this levodopa. Okay? Kasi pag discuss ko na yun lahat in detail, ay naku, parang ako nag-actual review ng buong concept. Okay? Clear? What else? Meron ba tayong surgical procedure nito? Meron tayong surgical procedure for Parkinson's, but it will not cure the patient's the patient's problem. You call that as your stereotactic procedure. Procedure. Uh, there are two common procedures. Ano nga yun? Thalamotomy and palidotomy. Thalamotomy and palidotomy. Palidotomy. These procedures will not cure Parkinson's. These procedures will just decrease the triad symptoms. Will decrease the triad symptoms. It will not cure Parkinson's symptoms. Okay? Clear? Okay, hold on. Baka may tanong dito sa kabila. Ano din isa? Ano pa to? Remove scattered rugs for pillow. Yes, because remember, I said priority is your safety. PTB, INH. Welcome po, Raisa. Kaya mo yan. Tara nito. I like that, guys, when you support each other. That's the purpose why we're here. Okay? That's the reason why. Actually, that's the reason why I give free lecture. Yung mga bits and pieces lang ng concept. Just to help you. Meron pa, may mga tanong ba dito? Okay? Oh, what else? What else do we have here? Okay. Whiteboard. Ito na lang gawin ko. Ilagay ko na lang siya sa isang malaking table. Yun na lang. So that's what I'm going to do. Ilalagay ko siya sa pinakamalaking table lahat na neurologic problem para mas madali niyo siyang makita. Okay? And don't forget, I want you to screenshot this because this will be your guide. So, lagay natin dito, disorders. Okay? Here, no. Lagay ko na lang dito, factors. Ano ba yan? Factors. Okay? Mga sakit dito, let's say, multiple sclerosis, Guillain-Barré syndrome, myasthenia gravis. Then we have your Parkinson's disease, amyotrophic lateral sclerosis, or your Lou Gehrig's disease. Okay, ito na lang gawin natin para isang table. Okay, here, autoimmune. Okay, number 2, kung may weakness ba siya. Number 3, what deficit is it? Is it sensory or motor? Okay, number 4, pattern of weakness. Number 5, earliest signs and symptoms. Number 6, what do you call this? Common diagnostic tests. And then 7, kung may constipation ba siya. Number 8, anong common meds na binibigay? Ayun na lang. Oh my God. Ayun na lang gawin natin. Ayan. Okay. Ayan. GS. MG. Hey. Ayan. Okay. So multiple sclerosis, is multiple sclerosis autoimmune? Yes. Is GBS an autoimmune? Yes. Is myasthenia gravis autoimmune? Yes. Is Parkinson's disease an autoimmune? No. Okay. What is Parkinson's disease? It's not autoimmune. I said it is degenerative. Degenerative. Okay. What about ALS? Is ALS autoimmune? No. What is ALS then? ALS is a motor neuron disease. It affects the motor neurons. Okay. There is damage, death of motor neurons. Do we have weakness in multiple sclerosis? Yes. Do we have weakness in GBS? Yes. Do we have weakness in myasthenia gravis? Yes. Do we have weakness in Parkinson's disease? No. Sabi ko, ano yon? Resting tremors, bradykinesia, muscle rigidity, stoop posture, shuffling gait. Hello? Okay. Do we have weakness in ALS? None. What deficit do we have here? Multiple sclerosis, is it a sensory or motor? It's motor. GBS, sensory motor, motor. MG, sensory motor, motor. Parkinson's disease, motor. Kaklaro sa sinabi ko kanina, slowly progressive neurologic movement disorder. ALS ay motor neuron. Okay? Di ba? Ano ba yung multiple sclerosis, GBS? Pareho silang demyelination. Correct? So pag may demyelination, destruction of the myelin sheath. Okay? Myasthenia gravis, it's an autoimmune. It affects myoneural junction, causing weakness, okay, in the face, throat, and other voluntary muscles due to production of antibodies that will decrease or destroy acetylcholine. Parkinson's disease, nabanggit ko na, is a slowly progressive neurologic movement disorder, okay, due to a decrease in a neurotransmitter called dopamine. ALS is actually a motor neuron problem. There is damage in the motor neurons. Okay, let's talk about the pattern of weakness. What's the pattern of weakness for your multiple sclerosis? Because multiple sclerosis, it affects the brain and the spinal cord. So the pattern of weakness here is descending. GBS, peripheral demyelination, it's ascending. Myasthenia gravis, it's descending. Okay, Parkinson's disease, sabi ko nga walang weakness, so none. Here, none. Earliest. Ano yung earliest presentation ng multiple sclerosis? Visual disturbance. GBS, anong earliest niya? It's dyskinesia. Myasthenia gravis, still visual disturbance. Yung mga tinatawag nating ptosis, ganon. Diplopia. Parkinson's disease, nabanggit ko ng earliest ng Parkinson's, resting tremors. Resting tremors. Anong earliest sign ng ALS? Fasciculation. Fasciculation. Yung mga small fibers na nag-tweak. Okay? Ano yung mga diagnostic test natin dito? For multiple sclerosis, you have your MRI, okay? And you have your CSF analysis. In your CSF, it means that there's elevated protein in the CSF, and then there is elevated immunoglobulin G. For GBS, okay, you have your CSF, it means elevated immunoglobulin G. For myasthenia gravis, diagnostic test for myasthenia gravis is your tensilon test. Okay? Tensilon test. Dinidiscuss ko ito sa actual lecture. Tensilon test, you also call that as your edrophonium test. The medication given here is tensilon. We give it IV intravenously, 2 milligrams at a time. Hindi niyo pala ako nakikita. So sa tensilon test, you also call this as your edrophonium test. Okay, we give it intravenously, 2 milligrams at a time for a total of 10 milligrams. If after 30 seconds of administration, if there's of weakness, ptosis, diplopia, okay, for a few minutes, let's say 3 to 5 minutes, other book 10 to 15 minutes, it's positive for tensilon test. Okay, so that's your tensilon test. That's a confirmatory test for myasthenia gravis. Just watch out when you give tensilon. can cause overdosage of tensilon, and we call that your cholinergic crisis. Okay? So, isa sa mga highlight dito sa examination yung difference ng cholinergic crisis sa tinatawag nating myasthenic crisis. Of course, to know the difference between myasthenic crisis and cholinergic crisis, the test to be performed is your tensilon test pa rin. So, pag nagbigay ka ng tensilon at yung weakness ng pasyente ay lumala, yung weakness ng pasyente ay nag-exacerbate, yung weakness ng pasyente ay lumala, that is cholinergic crisis. Kapag nagbigay ka ng tensilon at nawala yung weakness ng patient, that weakness is due to myasthenic crisis. Okay? The antidote for your cholinergic crisis is your anticholinergic at your atropine sulfate. Okay. Anyway. Ang bilis ko magsalita, no? I-pause nyo na lang. Nasaan na yun? Whiteboard. Oh, here. I said in your PD, no laboratory test. We do here your PET scan. ALS, no specific test. Naalala nyo dati, ito yung ginagawa na ice bucket challenge. Do we have constipation in multiple sclerosis? Yes. In GBS? Yes. In MG? Yes. In Parkinson's? Yes. In ALS? Wala. Remember, in ALS, intact po ang ating GIT. Ano mga meds natin dito? Ang meds natin common sa MS is your ABCR. Isahin na lang natin to. Isahin na lang natin. Okay. So common meds here is your ABCR. A stands for Avonex, B stands for Betaseron, C stands for your Copaxone, R stands for your Rebif. Okay? In myasthenia gravis, we give tensilon, and we give mestinon, and then prostigmine or prostigmine. Remember, pareho silang pare-pareho silang may tawag nito, pare-pareho silang what do you call this? Autoimmune. So may common denominator sila, and what is that? That is your thymectomy. That's the removal of your thymus, thymectomy. Remember, thymus plays a vital for immunity. And there is a procedure. The procedure is almost the same done with your, just like your hemodialysis, but it's not hemodialysis. The purpose of this procedure is to reduce circulating antibodies. We call that as your plasmapheresis. Plasmapheresis. So the plasmapheresis is almost, the procedure is almost the same with your hemodialysis. But the purpose of your plasmapheresis is to decrease circulating antibodies. Okay? So Parkinson's disease, I already mentioned your levodopa. Okay, I said that levodopa must be given with carbidopa. Pag naibigay yan, ang tawag natin doon ay Sinemet. Okay? Ito, ongoing po yung research. Okay? I hope this is clear. Let me just give you a bird's eye view of this neuromuscular problems. I hope this will help you guys. You can take a screenshot. Okay? Okay. What else do we have here? What else do we have here? Management of cardiac catheterization. Okay. Yan na lang siguro yung last natin, cardiac catheterization. And I will give an overview about advanced directives, special power of attorney, DNR, yung mga emancipated minor law sa next na natin na online. Okay, whiteboard. Okay, here. So when I say cardiac catheterization, cardiac catheterization is a broad concept. Okay, so it could be a form of it could be a form of, what do you call this, angiography, or a form of angioplasty. Okay, so example here is your angiography or a form of angioplasty. Pareho silang cardiac cath. So ano yung pinagkaiba ng angiography sa angioplasty? Yung angiography is a diagnostic test. The doctor now will make a slit. It could be here in the radial artery, it could be here in the brachial artery, in the subclavian artery, or in the groin. Doctor will make a slit, insert a wire, and the doctor will thread it going to your heart. Once the wire is in place, the doctor will insert the catheter. Mauuna yung wire because the wire serves as a guide. Okay? So if the wire is in place, catheter is being threaded inside, and then once in place in catheter, the doctor removes the wire. Okay? And after that, the doctor will administer a contrast or dye. Okay? That's your angiography. So pag inject ng contrast or dye, the patient will be scanned, your fluoroscope will be scanned, makikita doon sa angiography kung saan banda yung obstruction, yung vascular abnormality. It will even identify the degree of obstruction, how many percent is the occlusion, what specific vessel is affected. That's your angiography. Okay? Pag sinabi ko namang angioplasty, that is the treatment. Okay? So that test is angiography. The angioplasty is the treatment. So in your angioplasty, the doctor will insert the catheter. It's just that the tip of the catheter it has a balloon. It's a balloon tip catheter. And then when the doctor threads the balloon tip catheter and reaches the occluded vessel, the doctor now inflates the balloon. So as the balloon inflates itself, it will compress the clot or the plaque. The main purpose of your angioplasty is to restore or dilate the vascular compartment. The purpose there, the goal there is to increase or restore at least 80%. Okay? At least 80%. Restore at least 80% sa occluded area. At least 80% yung idadilate niya. Okay? So that is your angioplasty. Sometimes, hindi pa conforme yung doktor, maglalagay pa siya ng stent. We call that as your coronary stent. Yung stent, it's made up of a wire mesh. Okay? So this is your wire mesh. I-enclose siya sa catheter, ng balloon tip, at sabay silang ipasok sa loob. Pag naipasok sa loob, when the doctor inflates the balloon, the wire mesh expands itself and dilates the vascular area. Okay? So since pareho silang catheter na pinapasok papunta sa heart, we call that in general term as cardiac catheterization. So yung coronary angiography, coronary angioplasty, general term is cardiac catheterization because we insert catheter. By the way, yung angiography pwedeng gawin sa heart, pwedeng gawin sa brain, pwedeng gawin sa lungs. So if pag ginawa yan sa brain, you call that your cerebral angiography. Pag ginawa yan sa lungs, you call that pulmonary angiography. Pag ginawa yan sa heart, coronary angiography or cardiac. Okay? Catheterization in general. I hope that is clear. Okay? Now, so when you talk about cardiac catheterization, okay, cardiac catheterization, ano yung mga dapat tandaan dito? Okay? Nursing alert. Nursing alert. Okay. Post-catheterization. Catheterization. Hindi pala. Not post. Umpisahan natin. In general. Okay, number 1. Allow the client to void. Kasi yung gusto i-discuss management, right? Allow the client to void prior to the procedure. Because there should be no disruption while the procedure is going on. Because remember, the doctor will make a slit in the artery, the patient will bleed to death. Okay? So there should be no interruptions. Allow the client to void prior to the procedure. Number 2, since the doctor will use a contrast for your angiography, okay? Since it uses contrast, huwag kalimutan check for allergies against what? Iodine. Okay? And since it uses contrast, at alam natin contrast are nephrotoxic, okay? So you have to check for the BUN, CREA of the patient, potassium level of the patient, and of course, urinary output. If the BUN creatinine is high, that is indicative of renal problem. Okay, so that will give a doctor a heads up. Oh, patient is having renal issue. So is it safe for us to give or continue using contrast or not? If the benefit outweighs the complications, usually gumagamit yung contrast yung doktor, pero ang ginagawa prior to the procedure is nagbobolus ng 500 to 1 liter of normal saline bago bigay yung contrast. Then after na ibigay yung contrast, magbobolus na naman ng 500 to 1 liter of normal saline to flush the contrast out. Okay? Yan yung common na ginagawa. But technically, we don't do contrast if the patient has renal issues. Okay? But at least alam nyo, may mga we bend rules. Okay? But generally in your examination, you watch out for renal problem. Okay? Next, number 3, do not forget this. Assess for peripheral or distal pulses. Okay? This must be done before and after the procedure. So for example, ang ginamit ng doktor ay brachial, okay? You have to assess distal pulse. Am I right? You have to assess, nasa na yun? Remove. You have to assess distal pulse, okay? And that is your radial. So before the procedure, assess. After the procedure, assess. There should be pulses before and after, okay? What about a weak pulse after the procedure? That's fine, okay? A weak pulse is fine. Next. Nasa na yun? Whiteboard. Okay. Next, number 4. Don't forget this. Post-procedure. Post-procedure. Okay. Position. What is the best position post-procedure? What is the first and what is the second answer in your exam? The best position post-procedure is actually supine. Okay, flat. Okay, flat, supine. Pag wala yan, you can elevate head of the bed but not greater than 20 degrees. Okay? Next, post-procedure. Don't forget this. Apply direct pressure. Where? Site. Why will you apply direct pressure on the site? To control or prevent bleeding. Ang ginagawa na natin ngayon ay naglalagyan tayo ng occlusive dressing at saka velcro. Nilalagay to occlude. Dati-rate, if you can still remember in the Philippines, when you took the local board in the Philippines, ang sagot natin dito ay put sandbag over the site. Naalala nyo yun? Okay? Sandbag over the site. That sandbag is important in order to add direct pressure on the site. Okay? Then, what else? Post-procedure, of course, post-procedure increase oral fluid intake. Why? The reason why we do that is to facilitate dye elimination. Okay? And of course, you have to watch out for bleeding. Kaya yung sandbag sa Pilipinas ay ang ginagamit. Hindi yan dito applicable. Okay, so watch out for bleeding. Rax, did I answer your questions about management for cardiac cath? So ito yun. Okay. Got. Okay, so I think okay, kung wala ng tanong, thank you so much. At least nakapag-discuss ako. Anyway, may tanong pa dito. May essay. Yes, sandbag to add pressure. Sir, ang creatine clearance po, saan po siya need i-check? Sa mga pasyente may kidney problem yan, usually we check that. The purpose is to check the efficiency of your kidneys. Okay? How efficient is the kidneys removing waste products per minute? Okay. If you reached this far, thank you so much. Okay? Yung remove scattered drugs per PDS, kasi nga sabi ko, safety issue. Yung advanced directive ni Sean, I will discuss that maybe tomorrow. Okay, hold on. Let me check if I have a slides for that. That's nursing issues. Well, surprisingly, I have slides for that. Ito yung slides ko. Negligence, liabilities, bill of rights, informed consent, ayan, advanced directive. Anyway, I will explain that soon. Just keep posted, Sean. Don't worry, just keep posted, and I will try to discuss that. Risa, thank you so much, Sir John. Mag-prepare na po ako for duty. No problem. Okay. Thank you so much, guys, for staying, and I hope you learned something. Okay. God bless everybody. Keep safe. I'll see you soon. Bye.